We distinguished between pharyngitis and bacterial rhinosinusitis and looked at causative pathogens. We looked at empiric treatment for bacterial rhinosinusitis and streptococcal pharyngitis. Now, let's recommend an appropriate duration of therapy for rhinosinusitis and pharyngitis. So when it comes to acute bacterial rhinosinusitis, our first line recommendations are oral amoxicillin clavulanic acid, and this is typically used for 5 to 7 days. Alternatively, you can just use amoxicillin alone if the patient is not at risk of drug-resistant Moraxella catarrhalis and H. flu. That is also used for 5 to 7 days. Amoxicillin clavulanic acid is more likely to cause diarrhea than amoxicillin, so sometimes a patient cannot tolerate amoxicillin clavulanic acid because of diarrhea. You may want to use amoxicillin instead. Now, if someone has penicillin allergy, they can get doxycycline for 5 to 7 days, or levofloxacin for 5 to 7 days, or moxifloxacin for 5 to 7 days. So levofloxacin and moxifloxacin are respiratory fluoroquinolones. And if someone has anaphylactic reaction to penicillin, you still use any of these because they're not beta-lactams. For acute streptococcal pharyngitis, the first line recommendation is penicillin V, which is the oral formulation of penicillin for 10 days. Or alternatively, amoxicillin for 10 days. Or you can do a one-time intramuscular injection of penicillin G and be done with the treatment. If someone has non-anaphylactic reaction to penicillins, they can actually get cephalosporin. So they can either get oral cephalexin or oral cefadroxil, and these are for 10 days. Now, if someone had anaphylactic reaction to penicillins, then they can get clindamycin for 10 days or azithromycin for 5 days. This concludes this presentation.